Okay, next is psoriasis. So it can be divided into type 1 and type 2. Type 1 is presenting less than 40 years old and has a positive family history associated with HLA-CW6. Whereas type 2, you can see that it presents more than 50 years old and with no family history. Features can be red scaly plaques, scalp extensor surfaces, elbows and knees, sacrum. In these areas, nail signs, pitting on onycholysis, arthritis. And exacerbating factors are alcohol, trauma, drugs like beta blockers, lithium, anti-malarials like chloroquine, hydroxychloroquine. This can exacerbate psoriasis. NSAIDs and ACE inhibitor, systemic steroid withdrawal. So what you need to remember is where they are presenting, like scalp extensor surface, and also cause can be abnormal T cell activities. Stimulates keratinocyte proliferation, so it's basically keratinocyte abnormality rather than an actual primary keratinocyte disorder. So T cell is the main culprit, mediated by T1 helper cell, type 1 helper T cells. Okay. So treatment first line for all sites is emollients with lifestyle modification like smoking, alcohol, weight, and stress management. Trunk, limb, and gutted. Um, for trunk, limb, and gutted, you can give potent topical corticosteroid plus topical vitamin D preparation once daily. Apply for 4 weeks. If the above is ineffective, cold tar can be given, but this is subject to change. Like you can see different guidelines in the new nice guidelines. And face flexures and genitalia, you can give moderate or mild or moderate potent topical corticosteroid. If ineffective, topical calcineurin inhibitor, tacrolimus or pimecrolimus as well can be given. So the mainstay of treatment is corticosteroid. Here topical and vitamin D as well, and even if ineffective, can add also calcineurin inhibitor like tacrolimus. And for scalp, cold shampoo in combination with potent topical corticosteroid, alternatively vitamin D if steroid not tolerated. Okay, if not effective, corticosteroid plus vitamin D. It's almost the same thing coming again and again. And if not effective, very potent corticosteroid or cold tar, not shampoo. So phototherapy can also be used like wide or narrow band ultraviolet B lights. 313 to 313 nanometer is now the treatment of choice. Photochemotherapy is also used, Sorlin and ultraviolet A, like light called PUVA. Adverse effect can be skin aging, squamous cell carcinoma, not melanoma. Systemic therapy can include methotrexate is useful if associated joint disease. Biological agents like infliximab, etanercept, adalimumab, ustekinumab is shown promise in early trials. Cyclosporin, systemic retinoids. Okay. Gutted psoriasis is another important thing. It's also known as eruptive psoriasis. More common in children and adolescents in the younger age. It may be preceded by streptococcal infection 2 to 4 weeks prior to the lesion appearing. So the difference between the other ones is like this: is an infection before the lesion coming up, 2 to 4 weeks before. So features can be teardrop papules, small, 0.5 to 1.5 centimeter diameter lesions over the upper trunk and proximal extremities. And management, most cases resolve spontaneously within 2 to 3 months. There is no firm evidence to support the use of antibiotics to eradicate streptococcal infection. Um, Topical agents as per psoriasis, ultraviolet B therapy can be given, and tonsillectomy may be necessary with recurrent episodes. So, a streptococcal infection followed by psoriasis is called gutted psoriasis or eruptive psoriasis. Next is important toxic epidermal necrolysis, a very important topic as well. Potentially life-threatening skin disorder that is mostly secondary to a drug reaction. So, like Steven Johnson also is there. In this condition, the skin develops a scaled appearance over an extensive year, scaling. Some authors consider TEN to be a severe end of a spectrum of skin disorder, which includes erythema multiforme, that one I said, Steven Johnson syndrome. Features can be systemically unwell, like pyrexia and tachycardia. And positive Nikolsky sign, the epidermis separates from the with mild lateral pressure. So mild lateral pressure will separate the epidermis. Positive Nikolsky sign. Management can be stop precipitating factor, so it has to be due to a drug, so it will stop the drug. Supportive care, often ICU. IV immunoglobulin has been shown to be effective, is now commonly used first line. Other treatment options include immunosuppressive agents like cyclosporin, cyclophosphamide, plasmapheresis can also be given. Drugs which can actually cause this is very dangerous. Phenytoin, anticonvulsant, as you know, anti-epileptic, sulfonamide, sulfonamide, L-pyrinol, penicillin, carbamazepine, NSAIDs. All these are known to cause toxic epidermal necrolysis. Okay. Keloid scars. Okay. So they are like tumor-like lesions that arise from the connective tissue of a scar and extend beyond the dimension of the original wound. So it extends from the original wound. Okay. So predisposing factor can be more common in young black male adults, rarely in the elderly. Common sites in order of decreasing frequency. So sternum can be a common place for that. Shoulder, neck, face, extensor surface of the limbs and trunk. Keloid scars are less likely if incisions are made along relaxed skin tension lines. So the natural lines that are there, if you make a incision for a surgery, like parallel to the natural lines, this will be better for the prognosis. There's lesser chance of having a keloid scar. So treatment can be early keloids may be treated with intralesional steroid like what triamcinolone for keloid scar. Excision can be sometimes required. Langle lines were historically used to determine the optimal incision line. They were based on procedure line done on cadavers but have been shown to like worse cosmetic results. Okay. Acanthosis nigricans. Okay, this is something we studied in Cushing syndrome before, and it describes symmetrical brown velvety plaques that are often found on the neck, axilla, and groin, just like that. Internal malignancy like gastrointestinal cause, insulin-resistant diabetes mellitus, obesity, acromegaly, Cushing's disease, hypothyroidism, polycystic ovarian syndrome, familial Prader-Willi syndrome. Drugs like OCP, nicotinic acid can be causes of acanthosis nigricans. Okay, eczema, a very common skin disorder, an itchy skin condition in the last 12 months, or plus minus more of 3 of this thing. Itchy skin disorder will be onset below age of 2 years. So very early onwards, you can see you get patients with eczema, and then history of flexural involvement. So and history of general dry skin, personal history of other atopic disease like what? In children less than 4 years, history of atopic disease in the first relative may be included. And for 2 studies, history of flexural involvement or dermatitis on the cheeks and or extensor areas in children less than 8. So even in psoriasis, we remember studying for extensor surfaces being more affected with scaly red plaques. And here it's more of erythema, so dry skin as well. Management can be topical steroid, like moderate. You can use clobetasol butyrate, 0.05%. Potent can be betamethasone valerate, very potent. So that's clobetasol propionate. So CBC, if you remember, CBC in increasing order, and then this one is CB and the CP. So this is what you have to remember. Okay. So use weakest steroid cream which controls patient symptoms. Okay, so better to use the weakest one at first. Okay, topical steroids by potency. So mild can be like helped with hydrocortisone cream. Moderate with betamethasone valerate can also be used. Clobetasol butyrate, as mentioned here, can be used. Potent. These are both moderately potent. Very potent. More than moderate potent is betamethasone dipropionate or betamethasone valerate. This is the one given here, 0.1% potent. You can also use betamethasone dipropionate, is 0.025, and very potent is clobetasol propionate, 0.05%. So you have to remember the percentage and the name. So as you know, you can study this one as well. This is very good. Moderate clobetasol butyrate 0.05, betamethasone valerate 1%, clobetasol propionate 0.05%. Okay, fingertip rule. 1 finger unit. FTU is 0.5 gram, sufficient to treat area about twice of the flat adult hand. So twice of the flat adult hand. So this is one adult hand, twice of that. You can use that with 1 fingertip, 0.5 gram. Okay, so topical steroid dose for eczema in adults, area of skin. So how much of that 1 FTU can be given? Hands and fingers, front and back 1, foot all over 2, face and neck 2.5, enter arm and hand 4, front of chest and abdomen 7, backs and buttocks 7, and entire leg and foot 8. Okay, pityriasis rosea. So its cause is unknown. Herpes hominis virus HHV7 is a possibility. It tends to affect young adults. So what really happens? Hair will patch, usually on trunk. So it's better when you're studying dermatology. It's better to sit with your laptop and just check out all the things that are there online. That will be better for you. pictures are very much helpful. So a hair patch, you can see over the picture, it's a hair patch. So usually on the trunk, followed by erythematous oval scaly patches which follow a characteristic distribution with the longitudinal diameters of the oval lesion running parallel to the lines of Langer. This may produce a fur tree appearance. So fur tree will be like this, something like that. Fur tree appearance. It's self-limiting. So this is the key. Like in the question they can ask about this. And the known cause can be HHV7. Usually is appears by 4 to 6 weeks. Okay, pityriasis versicolor, that was rosacea, and this was versicolor. So this is called tinea versicolor, is also a superficial cutaneous fungal infection caused by Malassezia furfur, formerly termed as Pityriasporum oval. Okay, most commonly affects trunk. Patches may be hypopigmented like vitiligo, something like that, pink or brown as well. Scale is common, mild pruritus. Occur in healthy individuals. Immunosuppression, these are immunity predisposing factor like Cushing's, malnutrition, immunosuppression, or healthy individuals. Topical antifungals are used here, terbinafine or selenium sulfide. Topical antifungal. If extensive use or failure to respond to topical treatment, then consider oral itraconazole. So pityriasis versicolor versus pityriasis rosea. Acne rosacea is a chronic skin disease of unknown etiology. So typically affects nose, cheeks, and forehead, and the flushing is often the first symptom. Telangiectasia are also common, and later develops into persistent erythema with papules and pustules. Ocular involvement, blepharitis can occur. It's a chronic skin disease of unknown etiology. So nose, cheeks, and forehead, if you remember, flushing, if you remember, ocular involvement. Rhinophyma and development of a large bulbous nose associated with granulomous infiltration. This is how it looks. And so the management will be topical metronidazole, may be used for mild symptoms. Limited numbers of papules and pustules, no plaque, so that's mild. Most severe disease is treated with systemic antibiotics like oxytetracycline. Recommend daily application of a high factor sunscreen. Camouflage cream can help conceal redness, and laser therapy may be appropriate for patients with prominent telangiectasia. Okay. Acne vulgaris is a common skin disorder which usually occurs in adolescents. So acne vulgaris is a common skin disorder which usually occurs in adolescents. Typically affects the face, neck, and upper trunk, and is characterized by obstruction of the pilosebaceous follicle with keratin plaques, which results in comedones, blackhead, and inflammation in pustules. Pathophysiology is multifactorial, follicular epidermal hyperproliferation resulting in the formation of keratin plaque, hyperproliferation of follicular epidermis. This in turn causes obstruction of the pilosebaceous follicle. Activity of sebaceous gland may be controlled by androgen, although levels are often normal in patients with acne. Colonization by the anaerobic bacterium Propionibacterium acnes, inflammation. This is pathophysiology. And epidemiology is affects 8 to 90% of teenagers, 60% of whom seek medical advice. Acne may also persist beyond adolescence, and with 10 to 15% of females and 5% of males over 25 years all being affected. Acne may be classified into mild, moderate, or severe. Mild is open and closed comedones with or without sparse inflammatory lesions. Okay, and moderate acne may be widespread non-inflammatory lesions and numerous papules and pustules. So mild is basically comedones, and moderate is papule and pustules. Severe acne, extensive inflammatory lesions, sparse inflammatory lesion, non-inflammatory, widespread non-inflammatory lesion, extensive inflammatory lesion, which may include nodules, pitting, and scarring. C, PP, and DS. Scarring. Simple step-up management scheme of using the treatment of acne as follows. Single topical therapy can be given like topical retinoids and benzyl peroxide. Topical combination therapy like topical antibiotic benzoyl peroxide, topical retinoid. Oral antibiotics like oxytetracycline, doxycycline can be given. Improvement may not be seen in 3-4 months. Minocycline is not considered second-line treatment due to the possibility of irreversible pigmentation. Gram-negative folliculitis may occur as a complication of long-term antibiotic use of high-dose oral trimethoprim. If effective, it is effective if this occurs. Oral isotretinoin only under specialist supervision. There is no role for dietary modification patient there. Okay. Isotretinoin is an oral retinoid used in the term is an oral retinoid used in the treatment of severe acne. 2/3 of patients have long-term remission or cure following a course of oral isotretinoin. What are the adverse effects? It's very dangerous. Teratogenicity. Females must be using 2 forms of contraception for preventing fertilization. Dry skin, eye, and lips. The most common side effect of isotretinoin. Most common. Nosebleeds caused by dryness of the nasal mucosa, low mood, raised TG, and hair thinning. Benign intracranial hypertension. Isotretinoin treatment should not be combined with cetracycline for this reason. Okay. Next is Koebner phenomena. What is this? Describe skin lesion which appears at the site of injury. It's seen in psoriasis, vitiligo, warts, lesion planus, lesion sclerosis, molluscum contagiosum. Okay. Next would be a cafeole spots, very common in neurofibromatosis. So hyperpigmented lesions that vary in color from light brown to dark brown with borders that may be smooth or irregular. Causes neurofibromatosis 1 and 2, tuberous sclerosis as well, Fanconi anemia, and McCune-Albright syndrome. Granuloma annular, like that. Popular lesions that are often slightly hyperpigmented and depressed centrally. Typically occurs on the dorsal surface of the hands and feet and on the extensor aspect of arm and legs. A number of associations have been proposed to conditions such as diabetes, but there's only one weak evidence. It's not very much important. Keratoacanthoma is a benign epithelial tumor. It's a tumor. They are more frequent in middle age and do not become more common in old age. Unlike basal cell and squamous cell carcinoma, looks like a volcano crater, as you can see here. Initially a small dome-shaped papule, rapidly grows to become a crater filled with keratin. And spontaneous regression of the keratoacanthoma within 3 months is common, often resulting in a scar. Such lesions should, however, be urgently excised, as it is difficult to clinically to exclude squamous cell carcinoma. Removal may also prevent scarring. Okay, so the bullous disorders that are there can be very confusing when differentials are presented. Causes of skin bulla can be congenital epidermolysis bulla. Autoimmune can be bullous pemphigoid or like this, pemphigus vulgaris, and insect bite, trauma, friction, drugs like barbiturate and furosemide. Okay, bullous pemphigoid is basically an autoimmune condition causing subepidermal blistering of the skin like this. It's a secondary to development of antibody against hemidesmosomal proteins BP180, BP230. This is bullous pemphigoid, BP180, BP230. So antibodies against this hemidesmosomal protein is causing this autoimmune condition. It's common in elderly, itchy, tense blisters typically around the flexures. Mouth is usually spared, no mucosal involvement. It's very important. Bullous pemphigoid. So the difference between bullous pemphigoid and pemphigus vulgaris is this: no mucosal involvement. It's a major one. So skin biopsy, immunofluorescence, IgG and C3 at epidermal junction. You can see these in biopsy. And management can be referred to dermatology for biopsy and confirmation of the diagnosis. Oral corticosteroid are the mainstay treatment. And topical corticosteroid, immunosuppressant is also used. So if you remember one thing for this is it's an autoimmune condition and no mucosal involvement is there. Itchy typical blisters. Antibodies against BP180, BP230. Now pemphigus vulgaris is also an autoimmune disease and causing the same problem as well, but there is an antibody directed against desmoglein. A cadherin type epithelial cell adhesion molecule. It's more common in Ashkenazi Jewish population. PV Jewish. Okay, features can be mucosal ulceration, which is uncommon in bullous pemphigoid. So I don't know how you can correlate with this vulgar mouth. You can think vulgar mouth, mucosal. Oral lesions is there, vulgar mouth. That's how I can remember. Most mucosal ulceration is common and often the presenting symptom. So oral involvement is seen 50 to 70% of patients. So most of the patients will present with oral lesions, mucosal ulceration, and skin blistering, flaccid. So this is flaccid. This is not like very much like tense blisters. Flaccid, easily ruptured vesicles and bulla. Lesions are typically painful but not itchy. Painful but not itchy. That one was itchy. Okay. These may develop after months after the initial mucosal symptom. Nikolsky describes the spread of bulla following the application of horizontal and tangential pressure to the skin. Acantholysis on biopsy. Acantholysis on biopsy. Management can be steroid and immunosuppressant. So some certain points are there. Firstly, it's not involving mucosal ulceration. Secondly, it's flaccid. Thirdly, it's painful. And steroids and immunosuppressants can be used. Okay, next is molluscum contagiosum. It's caused by pox virus and common in immunocompromised patients. Flesh white or colored dome shaped and pearly in appearance. They are often 1 to 5 millimeter in diameter with a dimpled center. They are generally not painful, but they may itch or become irritated. Picking or scratching the bumps may lead to further infection or scarring. Myxoid cyst, also known as mucus cysts, like this one, are benign ganglion cysts often found on the distal dorsal aspect of the finger. There is usually osteoarthritis in the surrounding joint. They are more common in middle-aged women, so nothing much to remember. Important topic of dermatitis atopic. It's an autoimmune blistering skin disorder. So we all know from before it's like related to celiac disease. So it's an autoimmune blistering skin disorder associated with celiac disease caused by deposition of IgA in the dermis and itchy vesicular skin lesions on the extensor surface like elbow, knee, buttocks features. Management can be skin biopsy which show direct immunofluorescence shows deposition of IgA in a granular pattern in the upper dermis. So of course IgA in dermis, and management is gluten-free diet and dapsone. Dapsone can be. So now something which is very common, contact dermatitis. There are two main types of contact dermatitis: irritant contact dermatitis, common, and allergic contact dermatitis. Irritant one is non-allergic reaction due to weak acid or alkalis like detergents, often seen on the hands. Erythema is typical. Crusting and vesicles are rare. So just erythema. So it's irritant contact dermatitis. And for allergic contact dermatitis type 4, hypersensitivity reaction. This is a type 4 one. You have to remember this as well. Uncommon, often seen on the head following hair dyes. So this is when you put hair dyes on your head and shows allergy reactions. So type 4 hypersensitivity present as an acute weeping eczema which predominantly affects the margin of the hairline rather than the hair scalp itself. Topical treatments with a potent steroid is indicated. Topical treatment with a potent steroid. Semen is a frequent cause of contact dermatitis. The alkaline nature of semen may cause an irritant contact dermatitis, which while the dichromates in semen also cause an allergic contact dermatitis. So both can happen with semen. Nickel dermatitis is a common cause of allergic to contact dermatitis and is an example of type 4 hypersensitivity reaction. It's often caused by jewelry such as watches. It's diagnosed by a skin patch test. Nickel dermatitis. Allergy to watch. Okay, pompholics is a common type of dermatitis which affects hands, chiropompholics, and the feet. Pedopompholics, also known as dishydrotic eczema, causes acute vesiculobulbous itchy blisters. Triggers may include allergens, physical or mental stress, frequent hand washing, or metals. So small blisters on the palms and soles, pruritic, so it's itchy, sometimes burning sensation. Often blisters, burst skin may become dry and crack. Cool compress and emollients, topical steroids can be given. So this is very important. Porphyria cutanea tata. This is the most common hepatic porphyria. It is due to an inherited defect in the uroporphyrinogen decarboxylase or caused by hepatocyte damage, like alcohol or estrogens. Features classically present with photosensitive rash with blistering and skin fragility on the face and dorsal aspect of the hands, most common feature. hypertrichosis, hyperpigmentation, urine elevated or uroporphinogen, and pink fluorescence of urine under woodland. And management can be chloroquine venesection. This is something which is gonna come back soon. Very important topic. Okay, erythroderma. Okay, erythroderma is a term used when more than 95% of the skin is involved in any kind of rash of any kind. It can be caused by eczema, psoriasis, drugs like gold, lymphoma, or leukemia. Idiopathic can as well. Erythrodermic psoriasis may result from progression of a chronic disease during an exfoliative phase with plaques covering most of the body. It is associated with mild systemic upset. More severe form is an acute deterioration. This may be triggered by a variety of factors such as withdrawal of systemic steroid. Patients need to be admitted to hospital for management. Now, erythrasma is a generally asymptomatic flat, slightly scaly, pink or brown rash usually found on the groin or axilla. It's caused by overgrowth of diphtheroid corneobacterium, bacterium minutissimum. Examination with Wood's light reveals a coral red fluorescence. So this is with again wood light. Remember that wood light was previously wood lamp, Porphyria cutaneata, pink fluorescence of under wood lamp. Okay, so this one will be wood light, coral red fluorescence, and examination with wood light reveals this, and treatment can be topical miconazole or antibacterial are usually effective. Oral erythromycin may be used for extensive infection. And okay, photosensitive skin disorders. So basically, when do you see in this kind of disorders? This is increased by exposure to sunlight, like SLE, discoid lupus, porphyria, not acute with intermittent, just porphyria, herpes labialis, pellagra, xeroderma pigmentosum, solar urticaria, polymorphic light eruption. All these things can have photosensitive skin disorders. So a very important topic like Stevens-Johnson syndrome. We've talked about it before. Severe form of erythema multiforme associated with mucosal involvement. So features can be rash is typically maculopapular with target lesions being characteristic. So target lesions are there, may develop into vesicle serpula. Mucosal involvement is there, systemic like fever, arthralgias are there. Causes can be idiopathic. Bacteria, mycoplasma, streptococcus. Herpes simplex orf. Okay, drugs, penicillin, sulfonamide, NSAID, OCP, carbamazepine, allopurinol. It's a very common group. Concrete diseases like SLE, sarcoidosis can also occur, can cause the Stevens-Johnson syndrome. Malignancy can also do that. Tinea is a term given to dermatophyte fungal infection. Three main types of infection are described depending on what part of the body is infected. Tinea capitis, like scalp. Tinea corporis, trunk, leg or arm. Tinea pedis, feet. So let's start with the smaller one. Tinea pedis, athlete's foot, characterized by itchy, peeling skin between the toes, common in adolescents. Tinea corporis is in trunk, leg or arm. Causes include trichophyton rubrum, also causes fungal and nail infection, and trichophyton verrucosum. Well-defined annular erythematous lesion with pustules and papules, may be treated with oral fluconazole. Tinea capitis, scalp and ringworm, a cause of scarring, alopecia mainly seen in children. Most common cause of trichophyton transference in the UK and the US. May also be caused by Microsporium canis acute from cats and dogs. Diagnosis: lesions due to Microsporium canis under green fluorescence woodland. Okay, green fluorescence and okay, remember that. Okay, pruritus. So many medicines and these can cause pruritus. So let's see what are the differentials. Liver disease, of course. Firstly, history of alcohol excess, stigma of CLD, spiral nevi, bruising, pulmonary gynecomastia, etc. Evidence of decompensation, ascites, jaundice, encephalopathy, iron deficiency anemia. Pallor can be there. Other signs are chylomicria, atrophic glossitis, post-required web, angular stomatitis, polycythemia, pruritus, particularly after a warm bath, ruddy complexion, gout, peptic ulcer. CKD, lethargy and pallor, edema and weight gain, hypertension, lymphoma, night sweats, lymphadenopathy, splenomegaly, hepatomegaly, fatigue. Other causes can be hypo or hyperthyroidism, diabetes mellitus, pregnancy, senile pruritus, urticaria, skin disorders like eczema, scabies, psoriasis, pityriasis, rosacea. So, hirsutism or hypertrichosis. So, hirsutism is often used to describe androgen-dependent hair growth in women, with hypertrichosis being used for androgen-independent hair growth. So, hirsutism is caused by hormones, androgen. Just remember that. Okay. Cause of hirsutism can be PCOS, Cushing syndrome, congenital adrenal hyperplasia, androgen therapy, adrenal tumor, androgen secreting ovarian tumor, drugs like phenytoin can cause hirsutism. Remember that. And hypertrichosis drugs can like minoxidil, cyclosporin, dioxide, congenital hypertrichosis, for PCT, anorexia nervosa, GI, and lung malignancy. Assessment of hirsutism, Ferryman-Gilway scoring system. 9 body areas are assigned a score of 0 to 4. Score more than 15 is considered to be indicate moderate or severe hirsutism. Management of hirsutism, advise weight loss if overweight. Cosmetic techniques such as waxing, bleaching not available in the NHS. Consider using combined oral contraceptive pills such as Pyrindol, and this one, then there's all this can be used. Should not be used long term due to increased risk of venous thromboembolism. Facial hirsutism, topical eflornithine can be used. First line. Eflornithine can be used, contraindicated in pregnancy and breastfeeding. We're almost near the end of dermatology. Let's see the last two topics. Yellow nail syndrome, slowing of nail growth leads to characteristic of thickened and discolored nails seen in yellow nail syndrome, slowing of nail growth. Congenital lymphedema, pleural effusion, bronchiectasis, chronic sinus infection. Fungal nail infection, onychomycosis is a fungal infection of the nails. So causes can be dermatophytes, mainly trichophyton rubrum 90%, yeast candida, non-dermatophyte molds. Unsightly nails are a common reason for presentation. Thick, rough, opaque nails are the most common finding. What can you do? Nail clipping, scraping of the affected nail. Treatment is explored around 50% of people. Diagnosis should be, so it's not very much. Diagnosis should be confirmed by microbiology before starting treatment. Dermatophyte infection, oral terbinafine is currently recommended first line with oral itraconazole as an alternative. 6 weeks therapy is needed for fingernail infection, while toenails should be treated for 12 weeks. 6 weeks, 12 weeks. Candida infection, mild disease should be treated with topical antifungal like amorolfine, while most severe infection should be treated with oral itraconazole for a period of 12 weeks. Onycholysis describes the separation of the nail plate from the nail bed. And idiopathic trauma, excessive manicuring, infection like special fungal infection, skin disease, psoriasis, dermatitis, impaired peripheral circulation like Raynaud's, skin disease, hyper and hypothyroidism. So that's the end of dermatology.